All right, we are recording. So hello everyone. Welcome to this edition of Wednesday Night with a Master Therapist, which again is not being held on a Wednesday night. We're Friday afternoon, and we're also not obviously in the same physical place. We're doing it through a Zoom session. But we're still calling it Wednesday Night with a Master Therapist, because we do have a Master Therapist here, and I would like to introduce you to Bridgid Conn. We have to talk about terminology, but I was going to introduce you as someone with knowledge and expertise on their mental health and psychotherapy with individuals from the SGM communities, SGM standing for sexual and gender minorities. But when we were chatting a little bit before the interview, you were saying, I was trying to be very progressive in using these terminology, and there can be a problem with that, you were mentioning.
Well, I say it's not so much a problem in terms of being progressive and kind of considering terminology. I think, we were talking about how linguistics and terminology or how people self-identify changes over time. And, the idea of identifying as a person of a minority community can be empowering, can sometimes help people to sort of identify and access a sense of self as being part of a particular community. And for some, though, there can be a sense of, being part of a minority community might seem like I'm identifying in a way that with a community that has historically been oppressed.
Yes.
And has had a lot of like social disadvantage with it.
Right.
So, in terms of terminology, one type of terminology or one word that we use a lot in terms of coming from a strengths-based perspective is this idea of diversity, right? So folks of sexual and gender diverse backgrounds, which for some folks can feel, positive and empowering and inclusive, but, as I mentioned, I think it's always important to kind of reflect that back to the individual and identify, ask them like how they identify with the community or kind of have conversations about terminology.
About language, yeah.
About language.
Yeah. Okay. And so language is a part of a kind of open dialogue between the individual you're working with and yourself to try and create language that is comfortable, and for the person.
Right, that's inclusive, affirming. When I start in meeting clients, even just in the beginning, I talk about, my name is Bridgid. I use she, her pronouns, and understanding that folks may, between the times that we meet, have a change in how they identify or express their gender. So, creating sort of an open, affirming space in which we're making that part of the conversation from the very beginning.
Yeah.
So that they can feel comfortable to let me know.
Right.
Mm-hmm.
Okay, so a lot to talk about, but just for a little context, if you can tell the viewers a little bit about your background, your education, your training, and where you're working right now.
Sure. So I have a PhD in clinical psychology. I have focused the majority of my training, my education and training, and working with children, youth, and families over the last now, oh my goodness, almost over 10 years. I completed my PhD at Suffolk University in Boston, and I did training in schools there as well as in inpatient hospitals or inpatient units in psychiatric hospitals for children and youth and adolescents. I did my pre-doctoral internship at Primary Children's Hospital or Intermountain Healthcare in Salt Lake City, Utah, in the adolescent day treatment and residential program, as well as their community outpatient clinic. And then I completed my postdoctoral fellowship at Children's Hospital, Los Angeles, in the Division of Adolescent and Young Adult Medicine. So I have had a lot of broad experiences in working with youth and families, and I'm currently staff there, as well as a assistant professor of clinical pediatrics at Keck School of Medicine at USC.
I have to ask you, when you were in Boston going to school, and specializing in child and family, did you ever encounter an organization called Wadiko Children's Services? Did you hear about them?
It sounds familiar.
Because this is, if you did know about that, it would be kind of an overlap for us, because I also started my training in children and families, and I teach developmental psychology as well as clinical psychology. And my earliest training was in Boston at Wadiko Children's Services, and we did a short-term residential treatment center for emotionally disturbed kids who are having trouble being maintained in the Boston public school system, as horrifying as that may seem. And so I did that for a number of years before coming out to Los Angeles.
Oh, okay.
Yeah. So we both started with that specialization. And what is your days like working at Children's Hospital and at Keck? What are your sort of tasks and duties in your work right now?
Sure. So my role is pretty varied, and that's one of the things I love about my job, is that I provide clinical services, which can look like individual, family therapy, group therapy, on a daily basis with youth ages 12 through 21, sometimes older. I also do psychodiagnostic assessment. So some of us do continue to do assessment past our training, and that's something that I really enjoy doing.
Yeah.
I see assessment as part of a therapeutic intervention as well, helping young people to understand themselves better and understand their personal experiences, and kind of providing them with recommendations for things that would be helpful for them moving forward, whether it's at school, whether it's in therapy, at home, things like that. My role also includes supervision. So I supervise our interns and postdoctoral fellows in therapy. I'm part of the evidence-based practice training coordination, and my specialization is in cognitive and behavioral therapy. So I provide consultation and support in that arena. And then another hat that I wear that I'm really happy to be able to have, to be able to participate in still, is in research. So I support mentorship for our postdoctoral fellows for their scholarly projects if it's in an area that I'm also working in. And I provide analytic support, writing, overall research methodology support within our division on a couple of different research programs and projects.
And how much of your focus is in working with gender and sexual and gender diverse populations? Yeah, I'm learning my language now.
I would say, since we're moving to children's and having really formed some really good networks and connections with our different programs there, I would say a lot of youth that we work with identify as a sexual or gender diverse youth. And so I would say that's become a larger part of my work and advocacy in terms of doing training out in the community, presenting at conferences, just helping to kind of disseminate the work and the models that we use in our treatment in terms of creating gender affirming spaces, using gender affirming therapy, and to provide support for our youth.
And are some of the youth coming in for problems that are directly related to their sexual and gender diversity and some of the challenges related to that, or they may be coming in with a general mental health issue, not specifically related to that, and you're doing like CBT for anxiety or for depression or something like that.
I think, you know, the pathways in treatment are so individually driven, you know, in terms of someone's process and in terms of whether or not they sort of disclose upon intake or whether that's something that unfolds through the therapy process. You know, the point that I think you're bringing up in that question is really the understanding of intersectionality between our identities, you know, who we are and how, you know, models of minority stress really indicate that folks who identify or are identified by others, right, as a minority based on how we look, are the different ways in which we identify or express ourselves, all of that can sort of, as it unfolds, really quantifiably and exponentially, like, create greater feelings of stress and distress upon individuals. And that's really an interactional kind of experience with their environment. So are they in a school where they may have peers who are going through similar experiences there or identify similarly to them that they can talk to? Do they see role models or posters even that reflect folks who identify similarly to them? How are their families and friends in terms of when they come out and disclose? How do people react? And all of that can come together and really shape how someone presents in therapy. So it may not be sort of they come in and they say, I want to work on you know, my sexual identity, and I want to work on like coming out to my family, or I want to understand myself better. It may be that they have had knowledge for many years about these different aspects of their experience and the intersection of being perhaps a person of color, but also a person with trans experience and a person who identifies as pansexual. And sort of like the intersecting of those different identities within the context of support or lack of support can contribute to how somebody comes in to therapy. And then it's kind of up to us as clinicians to really create a space in which we say, you know, whatever it is that you're going through, I'm here to help you. I'm here to help hold a space for you so that when you are ready to share what your experiences are, I'm here to support you through that.
And you're seeing high incidence of mental health issues among individuals who are of diverse sexualities and gender. That is that a finding that is been documented?
Right. There's a lot of research support that shows that youth in these communities are, you know, just at so much higher risk or have greater vulnerability, right, for developing psychiatric comorbidities. We just know that there are so much higher rates of suicidal ideation and suicide attempts among our youth who identify as part of the LGBTQIA community. Yeah.
And that's more than other areas of diversity, ethnic, cultural, racial, is it on par with other areas of diversity or minority status, if you will, or is it even higher than some of the other areas of diversity?
What we know is that it's based on the literature that we've looked at, that it is higher. And I think, you know, when we think about what kind of creates increased vulnerability, right, for developing depression, anxiety, other mental health conditions, a part of that is sort of social support right? Community support for youth who are in their families not receiving support, right, around their gender or sexual identity, compared to perhaps their cultural background or race or ethnicity. We're seeing that there is in that mix, right, a greater disparity for youth who identify LGBTQIA+.
I wonder if we go back in the last century in terms of homosexuality, which was, in the early history of psychology, pathologized. It was seen as a mental disorder. And when there's a kind of pathologizing of a lifestyle choice or a life choice, it could be that sort of stigmatization that produces the higher incidence, then that might be a cause. I wonder if we go back into the early days when psychology was grappling at first with diverse sexualities, whether or not the incidence of psychological disorders, behavioral disorders, was higher in the gay community.
I think, we are always trying to improve upon the efforts of the past, right? We see, okay, based on what we knew at that time, what were folks trying to do, or right, like in terms of stigmatizing, and then we had a greater understanding in terms of diversity, a diversity of sexuality and gender experiences. And I do think, while we've made movement forward in terms of creating additional supports, resources, psychoeducation for communities and families, therapies that are really attempting to address stigma, shame, internalized homophobia, internalized transphobia,
that's why I think
still have work to do.
There was like the field has a template for how to respond in a humane way to individuals who have diverse aspects of their identity and lifestyle. And that maybe that template was worked out, through many mistakes and many kind of brutalities, with the gay community.
Absolutely.
Because I think that I think that there's more speed of responding in there's another piece of language, in an affirming, supporting, non-pathologizing way, and seeking to understand the people's experience much faster than I think how the field responded when it was grappling with the how to look at homosexuality.
In terms of understanding, like there's even a greater spectrum, right, of individual
it's an
experience.
expansion. We had to expand in some significant kinds of ways, but in a way, there is this template of tolerance and acceptance that we work through as a field. So I think that there's a possibility of moving forward more quickly.
Absolutely. And I think one of the areas in which we continue to expand is understanding, not just from sort of an internal perspective, but looking at the impact of more, proximal versus distal stressors on a person's mental health. So thinking about the fact that among homeless communities, youth from the LGBTQIA+ community are vastly overrepresented, right, in among those who are experiencing homelessness.
Because they're banned from their homes, or they find it unlivable.
Yeah, there's a lot of trauma that's experienced, a lot of rejection from communities. Youth talking about how they can't they have to live with not being their true selves, like not being authentic and genuine, to who they are, or they can no longer be in their community and no one wants to talk to them anymore. And that's a really, like, I can't even imagine being in that type of situation.
Yeah. So we can go back again to the cultural struggle with how to view homosexuality. And if we go back again to that early template, the same kind of thing happened. How many children were rejected by their parents or seen as deviant or something, and suffered a lot of emotional loss and abandonment and emotional trauma. So, and it's interesting to me as I talk to people both within the psychological community, even though I'm not an expert in this, like you are, but I think any therapist, anyone in the mental health field is being presented with these issues, more and more. So we're more familiar, with them. But for people outside of the mental health community that I meet, and most of them are, kind of, lefty progressive, types, they even though they may be fine, like if their child or something like that said that they were gay, they would go like, whatever, I hope you're happy. It's just so accepted and so okay for a lot of the people, at least in some of the urban progressive settings that I, run around in. But even among those groups, it's complicated for parents and family members to come to grips with the all of the diverse choices and orientations that are out there right now. So it's I could see why people still run into those areas where they essentially lose the support of their families at a young age. Be really, really tough. Yeah. So one of the things that I was reading as I was like preparing to talk with you that interested me a lot is a kind of rock and a hard place situation that many young people who are trying to find who they are sexually and in terms of gender face, in the sense that if they assert who they are or even assert the possibilities they're considering, they open themselves up to being stigmatized, discriminated against, and sometimes rejected, physically harmed in some cases. So that's a terrible situation. But at the same time, if they conceal who they are and what they're going through, then they live with this terrible anxiety about being discovered, or this terrible pain of going through the world in a way that no one is able to really see them. That's a really, really tough spot.
And that's why, in a lot of ways, when we talk about seeking any sort of treatment or intervention, right, whether it's coming in for mental health services, whether it's seeking medical services, these are all we view as life-saving interventions. Okay? Like for some families, initially, or even friends, teachers, whoever, they might be like, oh, I keep forgetting their name, right? Or it just it happens.
Yeah.
And there's a I guess a way we try to approach it where it's like, I understand it happens, and it's a matter of this person's livelihood, right? Their well-being, their mental health. Imagine someone saying something to you so triggering and so like unaffirming of who you are, because that is not how you see yourself.
So
And
they would use the name before they transitioned, for example?
yes,
Yeah.
right. Oftentimes referred to as a dead name.
A dead name.
A
Wow.
dead name, or they might say it's my birth name, or
Yeah.
currently my legal name,
Right.
if they haven't gone through the process yet of changing their name legally. Or they might say, they're not using my affirmed name, just their name. Um, and
And who are these people who would be making this mistake?
it could be family members, it could, siblings, teachers, it could be medical professionals.
Yeah, yeah.
There are times where sometimes we have to step in and say, whether it's in another clinical setting, we have to say, put on the chart somewhere a big sticker, something that has their affirmed name on it. And we think about these, there's recent research, I think it came out in 2017, that looked at the use of, in the article, they call it chosen name, but we
Yes.
talk about affirmed name. But in this article, they talk about chosen name for these youth, and the fact that, if I remember correctly, there was like a 71% decrease in depressive symptoms, and similarly, I think more so with suicide attempts, with the use of a youth's chosen name or affirmed name. And
Yeah.
that they looked at 4 different contexts. So there was home, school, I think work, and community. And in each setting, the more people use it in different settings across these 4 settings, with each additional setting, the positive impact increased for their mental
Yeah.
health.
I could definitely see that. I can also see that even a well-intentioned parent who has lived with this person for years and years and years,
Mm-hmm.
do you imagine the neural grooves that have been
Absolutely.
established in terms of using that particular name with your child be incredibly difficult.
Mm-hmm.
But I also see why the the use of the name and the acknowledgement that comes from that
Mm-hmm.
would be so incredibly important. I know that for me, when I've had clients who were transitioning or had transitioned or something, and sometimes I wouldn't have a problem with the name because I hadn't really had experience with them with
Mm-hmm.
their prior name or their given name. But the automatic reaction to apply masculine or feminine or non or binary pronouns with someone is so ingrained. Like you're just talking naturally and your mind almost unconsciously processes what you feel is the sex of the individual.
Mm-hmm.
Okay. um, and you blurt out the pronoun. So it takes a lot of mental effort and consciousness, I've found, not to occasionally make a mistake.
Right. And they say, the feedback that we are, I've heard from the community is they understand that it happens. A lot of our youth are like, it's going to happen. They've known me as this, my assigned sex at birth
Yeah.
for however many years. It's going to take some time for them to switch over. I think it's what matters and what sticks out to them is when people try, when people catch themselves, or they
Yes.
correct themselves and say, I remember yesterday I used the wrong pronouns, sorry, like I'm going to do it from now on, not to, and not, but I think there's a balance to that, not belaboring it and saying like, oh, I'm so sorry, and like kind of going on and on to the point where the other person has to be like, no, it's
Yeah.
okay, because then you're putting the
Exactly.
onus on the young person or the
I'll
other
tell you
person
what
to make
I've
you feel better.
done. Tell me if you think, if you were supervising me in this in this issue, whether you would think that this was a good idea. It's kind of worked, I think. So if I have a client who is transitioning, and I've had several of them, and or work with families that they were going through a transition together, their offspring's transition. At the beginning, I say to them that I am probably, I'm going to try my best to utilize the pronouns and the name that you feel comfortable with and have you chosen. I just want to apologize in advance, not out of any kind of bad intention, that I may make a mistake, a couple of times. And I just want to apologize in advance and tell you I'm going to, try my best to support your name and what it means to you. And they seem to be, fine with that. And then sometimes we've joked and said, they said, yeah, but you can't keep making a mistake. I said, oh, how many do I get before you get mad at me? And so we negotiate a number like 3 or something like that. And it sort of breaks the ice. And I think that's seen as not being overly heavy-handed, but registering the point that, I'm gonna try my best.
Absolutely. And I kind of create space and I say, like, if at any point you hear it, right, and I don't stop myself, please let me know, because I want to, in that moment, have an ability to check myself and self-correct, and that's going to help me in the future rather than waiting.
Yes.
So, definitely had people do that, or if, we're in a session with a parent and the parent is doing it, they kind of look at me and I'm like, let's, I might have been listening to something else, and then they look and we're like, okay, we're going to pause and we're going to have a moment in which we just say what we just said in the way that's using the correct pronouns or the correct name.
Yeah. Good. So I have one other complexity. I don't know if you've ever encountered this, but have you ever worked with a family of someone who is transitioning and they haven't fully transitioned male to female, female to male, and so they feel kind of a combination, so they feel that the best representation of their current identity to reflect that non-binary nature would be they and them. Okay, so I'm sure you've encountered that many times. The problem is if you have to write up case notes or some kind of report of the family work, then I have never solved the problem of they and them referring both to the parents as well as the offspring of the parents. And it creates these incredibly, almost incomprehensible sentences. The way that I've gotten around it is always just to refer to them by name, as opposed to, they referring to the parents or they referring to the offspring and confusing the reader. Have you encountered that?
I would say, I can't think of like a particular instance that comes to mind, but I would say that my automatic thing that I jump to is definitely just using the name.
Using the name, okay.
To avoid any potential like pronoun confusion in the documentation, to make sure that, like, if somebody's auditing, they know, who that particular intervention was aimed at, or things like that, that they don't have questions for me.
Right. Okay. Yeah. So what are some of the things that you think it's important for therapists to look for? You said that we need to be aware that there are a lot of mental health challenges and a lot of stressors that are associated, especially at this time in history and culture, that we're transitioning in a way to a wider, more inclusive notion of sexuality and gender. So we have to understand that this is tough terrain for people, and you may see some mental health challenges resulting. What about the incidence of trauma and suicidal ideation?
Mm-hmm.
So I've heard a lot of people with diverse sexuality and gender are pretty severely bullied at times.
Absolutely. There are just a myriad of different types of potentially traumatic experiences or self-described traumatic experiences that folks in the LGBTQIA communities have, right? And it may be absolutely like bullying around expression, around their partners. It could be, family rejection. Familial rejection is one that comes up quite a bit in terms of like non-acceptance. The worries of youth that their family is going to tell them that this is just a phase, right? You'll grow out of it, and not affirming and respecting where somebody is in that moment, like in terms of how they identify, and not accepting that they know themselves best. They're an expert of their own life.
Okay, I want to go on a tangent on there because this is one of the things I want to talk about. Then I want to come back to the suicidal ideation and the risk of suicide. This notion of a phase, or you'll grow out of this. In a parental sense, it would seem to me that, let's say you have a child who's 12, 13 years old, and they're telling you that they want to transition, that they feel that they're the other gender, and are talking about going through medical procedures. Is there any kind of guidance you can give? Do you support that? Do you affirm that? Or is there a way to affirm it but to delay any kind of physical modification of the body?
I think what you bring up is part of sort of like ongoing discussions in the community about like how best to support youth. And what we do know from research is that the wait and see approach ends up being very detrimental to youth's health. The whole like, oh, okay, we'll try again next year, or oh, like we don't want to do anything right now, like we want to wait until you're older. So just waiting and seeing and not accessing any consultation, any support for youth in which they can ask questions, they can get information, they can really talk through what their options are and make a decision for themselves about what feels right for them. There's a world or international organization, WPATH, that provides standards of care. So this is the World Professional Association for Transgender Health. And they came up with updated guidelines not too long ago, and they really provide the most up-to-date in terms of standards of care. And historically, mental health professionals have really acted as sort of gatekeepers for transitioning. And what we're trying to work towards is a stance of like being an ally and helping someone to reach the services that they need, regardless of age.
Okay, so let me just be clear about this. So the recommendation would be, let's say you have a preteen, let's say 12, 13, something like that, or a new teenager, and they are saying that they feel that their gender, their sense of identity is different than their assigned sex, and that they want to feel more whole and consistent and follow that path. Okay, I'm like, fine, let's talk about that and let's follow that process. And certainly we always want you to be an authentic person. And they say, yeah, and also what I would like to do is to begin taking hormones and maybe top surgery, maybe top and bottom surgery. Now, for some reason, I would have a hard time. And I don't know if this is something that I need to work on or whatever, but my first instinct would be, I would never oppose that. I don't know at what age, if you said that to me, I would support that and even support it financially. But I would be so frightened to support the process of serious modification of the body at such a young formative age. And I don't know if that's the wrong thing or that's a reasonable thing.
Well, I don't know, and I can't say, you know, what's right or wrong for each individual person, right? I think it's a process, and it's a discussion that happens with each family about what makes most sense for them. I think, you know, there are a growing number of gender specialists out there that would be really great resources to take a young person to and talk to them. When we have clients or when I'm meeting somebody and they're talking about these things, we talk about you know, if they're younger and the family is not wanting to move forward with surgery necessarily, is it, you know, taking blockers so that they have some greater window in terms of making those decisions in the future? Is it around helping them to socially transition and, you know, make that first step forward into living as their authentic self in different realms of their life? There are a lot of, you know, I think what we worry more for youth is that without intervention, without support, they start to do their own types of intervention, right? And we see, in terms of, we see that more with like self-binding in ways that are not healthy.
If the young person heard, in terms of these blocks, that the family system was hearing them and supporting their journey and to find who they are, but wanted to do that on a social level and psychological level, as opposed to an anatomical level, giving a young child who's in the middle of puberty, you know, strong hormones and things like that. Is your experience been that the child would accept that as a positive step forward? Or would they see that as blocking or ultimately standing in the way of who they are?
I think it depends on the youth. I think it depends on their process. If this is something they've been thinking about for a long time and they kind of, you know, we talk about this idea of like, sometimes youth feel like if I reach a certain physical stage, right? If I have the surgeries, everything will be better. Like my depression will go away, you know, I'll be 100% completely myself. And sometimes even post-surgery, there's absolutely a significant reduction for some folks, you know, in terms of their dysphoria, in terms of mental health symptoms, but it's not like a golden key that unlocks never-ending happiness, you know, never-ending happiness for them. It's a next step that makes sense. So I think if a family would be able to, with it, you know, gender affirming care is a collaborative process. It's not just one person meets with a family. Like even, you know, at CHLA with the Center for Trans Youth Health and Development, it's a multidisciplinary team that works with each person, right? In terms of case management, social work, adolescent medicine, you know, whether there's psychology involved. It's very much like providing the family with as much support as they need to be able to make decisions that are really adolescent centered.
Yeah. Is there any data on, because I think this would be important, is there any data on kids who have begun the process of physical transitioning, not social transitioning, but physical transitioning, at a very young age, when they do that, is that usually that they were right in that decision and that was the best thing for them? And even though it seems very early, that there are very few instances where the developing person would say that maybe I did that too quickly, maybe I was thinking that this was, what I needed, and I'm not sure that was the right decision. Or is that a rare kind of thing that usually they feel relieved, even if they began at a very early age?
I'm not as familiar with data on like much younger. I think that's especially in our country, right, compared to sort of internationally. I think there potentially is more data there. But in terms of this idea, like there was an article that came out years ago about this idea of desistance in terms of transitioning. And while there may be anecdotal evidence, like occasional cases of folks who write their story and they say like the transitioning wasn't the right decision for me, that's actually a very small percentage of our youth who transition end up wishing they hadn't.
Because here's, in the non-professional community of parents, they might say, oh, let's wait a while and see if you want to do that. And that could be their hesitation. In the therapeutic community, what I've heard for people who are not as aware, which is most therapists really, who may have some support and understanding of this, and they do affirm that process. Mm-hmm. But their worry is that the person may be going through a lot of mental health issues and a lot of confusion. And then this gets concretized in terms of I'm in the wrong body. Like I don't feel right becomes I'm not in the right body or the right gender, as opposed to they're sort of somaticizing a kind of a more mental health and personality confusion. That's what I see among therapists.
Yeah, I hear what you're saying, and I feel like in terms of, I guess, literature that I've been exposed to, some of that is sort of historically, like just in sort of previous generations of training, like that has been the view, is like this is like a transformation of one's trauma, or that this is related to sexual trauma. And I think that was part of the stigma and the role that mental health professionals had in sort of blocking people from reaching services. Because if you were to say to somebody like, you can't access affirming care, though this is how you identify and you feel you feel much more sort of an integrated person when thinking about going through transition and living as your affirmed self. That, historically as mental health professionals, we sort of said, like, if you don't, you can only proceed forward if you don't have any mental health issues, right? We want to make sure, but if somebody's experiencing severe gender dysphoria and rejection and not receiving services has actually created more vulnerabilities to being a victim of a hate crime, or being, as I say, clocked, right? And they aren't living as their affirmed selves, then we're actually kind of creating a bind for them in which there's no winning.
Yeah. I just thought of a great example. There's an actual clinical case that I was involved in which there was a trans male who, as a young girl, was sexually abused by her father repeatedly, and that there was some vague sense that the father had shared her with other men in a pedophile ring. So this is, you know, I mean, grotesque trauma, okay? And so the girl transitioned at a fairly young age to being a male, or yeah, trans male. And there were discussions in a case conference that it was interesting that when the transition occurred to being a male, the abuse stopped, because there was some thought that it was that the father was a heterosexual pedophile. So by transitioning to being male, it was protective of further abuse. Mm-hmm. That was one thing that was talked about. And therefore, is this a dynamic trauma response as opposed to a true transition in one's genuine identity? How are we supposed to look at this? Very complicated. Mm-hmm. So anyway.
Right, it's absolutely complicated in terms of like a lot of our youth in the LGBTQI community have experienced some level of trauma, right? Whether it's sexual trauma, neglect, physical abuse, and there are those theories, right, about like how sexual trauma might influence the development of gender or sexual identity. And you know, that's a very, like you said, complicated, complex, and complex situation in terms of like parsing that apart. In our experience, and what the literature shows is that though there are higher rates of like sexual abuse, that does not necessarily lead to like the switching of one's gender identity.
Yeah, I mean, I've been taking these the devil's advocate, or trying to represent people who play the devil's advocate. But to me, I feel that the child, whatever age they're in, that maybe there are some children who somaticize or personality issues or trauma or something, and it gets morphed into issues of gender and identity. But I think that in the vast majority of cases, that the child is like not making it easier on him or herself by transitioning in this climate. It's like, it's not something that you're going to like say, oh, that's so great, I'm in for just a wonderful experience. Mm-hmm. It's a great cost for the most part. So I take it more seriously, and I think that in the vast majority of cases, the child is not looking for something other than, you know, desperately wanting to be whole and real.
Absolutely. And I think, you know, going back to what we were talking about in terms of like family support, and maybe, you know, saying like, hey, let's slow down, and some of the concerns sometimes I feel like that family have are worries about what will happen to their child, right, when they transition. You know, and I think they can acknowledge in some ways perhaps this will help them to, you know, feel more authentic, more like themselves, you know, to be themselves like in all ways. But I do hear also, you know, in the family communities that they're like, I want to support my youth, but I'm so scared about what this means for them as being part of the community now.
Yeah, valid, although no reason to stop.
Absolutely. So it's like the both end of like, we understand your fear of, you know, because they see on the TV like hate crimes in trans communities of color, right? Or against trans communities of color.
That goes back to my, you know, comments, you know, this rock and a hard place. I mean, you go and you're a real person, and you open yourself up to really hurtful and potentially dangerous circumstances in your life. But if you don't, you live a life where you're not authentic and genuine, which is another kind of assault to the self. I mean, it's a very tough choice, that people face. And I don't think that they transition lightly.
Right. And it goes to, what you had brought up before around like rates of suicide. And when we talk about social and medical intervention, particularly in the gender diverse community, we're talking about really trying to provide supportive and affirming services that will help someone see their future, and when it's interesting when I do a lot of training in suicide prevention and intervention for adolescents and young adults in the community, but as well as like in our programs. I do a lot of that work. And, one of the questions that often gets asked as part of like a suicide risk assessment is, about hopefulness for the future, right? And, or can you see a future? And for some, for a lot of youth, they're, when we're talking about risk assessment, they're like, oh yeah, I can think about, what I want to do next week, or I can see myself graduating high school, or I can see myself going to college, and I have these ideas of like having a family, and, it helps them to think about their future. And then if you talk to some youth, they're like, I can't imagine what will I look like in the future, because my future self does not look like this.
Yeah.
My future self's body is not this body.
Right. Talk about uncertainty.
It's hard.
Yeah.
To do that kind of assessment and to think about, for a lot of our youth, if we were to ask them, they would all come up, not all, but like many of them might come up flagged as high risk, because they can't imagine themselves or can't picture themselves in the future, or thinking about, well, I'm transitioning. Can I have a family? What will that family look like?
Yeah.
If I want to get married one day, but who's going to be there? I can't even picture. Like when I come out and I say, I introduce my family to my partner, like what will my wedding look like? So thinking about even that very vital question that we ask about in suicide risk assessment being such a nuanced and important question to ask for our youth.
Yeah. So when you're working with them, you in some of the emails that we had, you mentioned a model of therapy, affirming therapy, but also there was another term, resilience, or what was
and I'm happy to share if it would be helpful, to send you some information, afterwards if you want to share it with folks. But there's the transgender resilience intervention model.
Right, that's what I was referring to. Yeah.
And that's grounded in originally thinking about the minority stress model, which was developed for understanding stress, particularly within the sexual minority community.
Yeah.
But has been expanded to think about the experiences of trans individuals. But these models really take a multi-level, like ecological approach to understanding the impact of stress. And the purposes of these models are to really understand the importance of intervention at each level and what those interventions might look like. So in terms of the individual level, thinking about how do we utilize like trans-affirming CBT, which is the type, one of the types of gender-affirming therapy I was mentioning in the email, to address and internalize trans negativity, the stress of concealing their identity if they haven't started socially transitioning, like just general sort of depression, anxiety.
That would be the individual context. And then what are the family be the next?
So group level, there's family, friend, and peer rejection or lack of support. So at the next level, we would consider interventions to develop social networks, or potentially family-based interventions to help family members. And there's a real it's more of like a relationally based therapy. There's a group out of, I feel like it's Drexel, and they do family intervention, so attachment-based family therapy,
Mm-hmm. Mm-hmm.
um, which is really process-oriented, trauma-focused, and works with the youth and their families on addressing potential like rejection that they experienced, hurt, like from an attachment perspective.
Yes, yes.
Um,
So you have the individual, you have the family and social network level, and then what about more community and broader culture?
yeah, at the highest level, we talk about like sort of the societal level.
Yeah.
So understanding the impact of discrimination, stigma, hate crimes, as well as barriers to accessing services, whether it's legal services, educational services, and that all of that is more of an advocacy or um, social level type of intervention that even as mental health professionals we can engage in,
Yeah.
and we can encourage our clients to engage in. And these might look like, how do we create affirming spaces in our offices? Like, if we have pictures of youth, or like kind of like those promotional posters or things like that, how do we create a space that is representative of folks of different intersecting identities, so
Mm-hmm.
they don't come into a space and say like, I'm looking around and nobody here looks like
Agreed.
me on
Yeah,
the wall.
yeah. Mm-hmm.
We talk about social advocacy to promote trans rights and support trans affirming laws. I think it means a lot in the community, at least with folks that I've spoken to, when they see us as professionals show up in different spaces to really support and encourage advocacy,
Mm-hmm.
promote trans affirming practices. So talking to colleagues, providing consultation or with our peers and saying like, I'm learning about this, can I share this with you, so that we can really provide the best support. In some of my work, they're like, okay, you came in for therapy, let's work on these things. But honestly, I try to be flexible in my work, and some of my work is around helping them to access legal services to change documents.
Right.
um, so okay, so here's a legal clinic that's going to be there on Friday. How can I help you like look for, if some of our youth don't have access to a computer, like how can I help them
Yeah. Yeah.
find this information, or they can't print things, like how can I get them those documents, so that I'm reducing the amount of barriers that they have to receiving these interventions.
Yeah, I love that. I mean, it's a very, as you say, multidimensional, all-encompassing effort to support the person
Mm-hmm.
um, in all the contexts of their life. Anyway, we're getting toward the end. If you could, no urgency on this, send me the resilience model, the resilience therapy that you were talking about, and then if there's any article you can direct me to read about what they're doing at Drexel on the family level, I will pass those along to the students in the class. So they can read some more about it.
Absolutely.
So I want to thank you so much for participating. This was really, I mean, it's so on the cutting edge of some of the things that we're dealing with as a society. I think it's important work, and I think not just for the public at large, but for current therapists and also aspiring therapists. This is something we all need to know more about, and I appreciate your giving us some really helpful information.
Well, I thank you so much for having me. I appreciate the opportunity to be here and to share some of the things that I've learned. I consider myself, I try to walk into spaces and in my work with a beginner's mind, and think like, no matter what, even though I might have, read, taken classes, or working with the community, I'm constantly learning.
Right.
And so I think, yeah, I just appreciate being here and being able to share what I've learned. And I hope that as a community, of professionals and aspiring professionals, that we can continue to learn together and
Yeah.
to shape the landscape for their youth and families and individuals that we work with, to continue to promote their mental health and well-being, and so that there can be like more hopefulness and success for them in the future.
Well said, and I hope that does come about as quickly as possible. All right. Have a good rest of the day, and again, I appreciate your coming on.
Thank you so much.
Okay, bye-bye.